Appropriate airway management is a key step in the resuscitation of a patient. These icons represent the individual steps for airway management. Pay special attention to them. Take body substance isolation precautions. Prior to performing the procedure, take and verbalize body substance isolation precautions and quickly put on protective gloves. It is also highly advisable whenever working around a patient's airway to wear protective goggles and a face mask if possible. Perform an initial assessment. When you encounter a patient, first you must determine whether the patient is alert and oriented, responsive to verbal stimuli.
Can you hear me?
Responsive to painful stimuli, or unresponsive. The acronym used to assess a patient's level of consciousness is AVPU: alert, verbal, painful, and unresponsive. When assessing the airway, it should be free of gasping, gurgling, wheezing, and snoring. If the person is unconscious, use the look, listen, feel method to determine if the airway is open. Look for the rise and fall of the chest. Listen for breath sounds. And feel for breath coming from the patient's nose or mouth. Open the airway. The airway can be opened using the head tilt, chin lift maneuver, or if a head or spinal injury is suspected, by the jaw thrust maneuver. To perform the head tilt, chin lift maneuver, kneel beside the patient's head. Next, place one hand on the patient's forehead and apply firm backward pressure with your palm to tilt the head back. With your free hand, place the tips of your fingers under the chin and lift the jaw upward. Again, it is important that you do not perform this maneuver if you suspect head or spinal injury. In these cases, the jaw thrust maneuver should be performed. To perform the maneuver, kneel at the top of the patient's head, carefully reach forward, and gently place your hands on the sides of the patient's lower jaw. Stabilize the head with your forearms, and using your index fingers, push the lower jaw forward. Use your thumbs to help position the lower jaw to allow breathing through the mouth as well as the nose. Inspect the upper airway. Quickly assess the upper airway for visible fluids, secretions, or a foreign body airway obstruction. If the airway is not open, it will need to be cleared through suctioning or another airway clearance maneuver. Suction the airway if necessary. If the airway is obstructed, suction may need to be performed. Position the patient appropriately and suction the airway according to local protocols. Choose an airway adjunct. Common airway adjuncts that aid in maintaining an open airway include an oropharyngeal airway known as an OPA or a nasopharyngeal airway known as an NPA. If the patient does not exhibit a gag reflex, an oropharyngeal airway can be utilized. If the patient does exhibit a gag reflex, an OPA is contraindicated and a nasopharyngeal airway must be used. After determining the appropriate adjunct, you must select the appropriate size of the device. To determine the appropriate size of an OPA, hold the airway up to the side of the patient's jaw and measure it visually from the earlobe to the corner of the mouth. To determine the appropriate size of the NPA, hold the airway up to the side of the patient's face and measure it visually from the earlobe to the nostril. An advanced level provider may choose to use an endotracheal tube or ET tube, laryngeal mask airway, or an LMA or a combi tube. Using ET tubes require direct visualization of the glottic opening, whereas combi tube, LMA, and King LTD airways are common blind insertion airway devices. If you are using one of these devices, be sure to observe local protocols. Insert an airway adjunct. The first step to inserting an oropharyngeal airway is to make sure the patient's mouth is opened properly. In order to open a patient's mouth, perform the cross-finger technique. Place the thumb and forefinger of one hand on the upper and lower teeth at the corner of the patient's mouth. Next, spread the fingers to open the mouth. Once the patient's mouth is open, an oropharyngeal airway can be inserted. To insert an OPA, kneel beside the patient's head and position the airway with the tip facing the roof of the mouth. Next, slide the OPA along the roof of the mouth. Rotate the airway 180 degrees as the tip reaches the back of the tongue, and gently advance the airway, adjusting it so that the flange rests against the patient's lips. Note, if the device is too large, remove it and choose the proper size to prevent occlusion of the airway. To insert a nasopharyngeal airway, push the tip of the nose upward gently and choose the larger nostril if a size difference is evident. Apply a water-soluble lubricant to the NPA where it will be inserted into the nares. Position the tube so that the bevel of the airway faces toward the septum and advance until the flange rests against the nostril. Note, do not force the NPA. If there is resistance, try placing the tube in the other nostril. If resistance continues, verify that the NPA is the proper size. Note, do not insert an NPA if a clear cerebrospinal fluid is visible and coming out of the patient's nose or ears, as this may indicate a skull fracture. Ventilate the patient if necessary. If breathing is inadequate, you may ventilate the patient with high concentration oxygen using a bag valve mask. If the ventilations are adequate, oxygenate the patient by using a non-rebreather mask. Monitor the patient. If the patient gags, vomits, or starts to regain consciousness, remove the airway immediately. Remove the oropharyngeal airway by pulling it out in line with the natural curvature of the mouth. Remove the nasopharyngeal airway by slowly pulling the NPA. Suction the airway as necessary. Perform an ongoing assessment while transporting the patient.